Sena Kaplan ve Hacettepe Üniversitesi Doçent Doktor.
From Hacettepe University, Miss Duygu has come, and our third session is about to start.
Değerli konuklar, Lösev,
Well, I'd like to welcome you to the third session, the afternoon session of this symposium. And today, in this session, we'll be talking about resilience and the social aspects of the oncology nursing. And without further ado, I'd like to invite Gülcan Bağcıvan from Koç University. She's an associate professor, and she will be talking about national and international education opportunities for oncology nurses. And we will be more than happy to hear what she has to say. Hello everyone, I'd like to thank everyone. Thank to the organizing committee for this symposium, and I'd like to thank to the executive committee, and I hope that I'll be able to contribute to the fruitful discussions. I'm in Koç University, and I am an internal specialist and nurse. I'm a clinician and an academician, and I'm an associate professor, and I am actively involved after 2007 in the Turkish Oncology Nursing Association, and I have been in the commissions, I have been in the steering committee, and now I'm in the research. I am the chairperson of the research department. As of 2023, this has been quite an amazing journey, and because I have been in the executive boards, and I am representing my country, and also we have some Balkan countries that we've been working with, and I'm representing them as well. But it's been a huge burden on my shoulder, but I'm really happy to be representing all these countries. And also, this is not a personal statement. I think as I'm introducing myself, there is a global power of oncology nursing formation. This has not yet been a association. This is just a formation now, and I'm in the steering committee, and I'm a representative in the steering committee of this formation. And here we have been trying to better the outcomes of the treatment of the cancer patients in the least developed and least developed countries and underdeveloped countries. And I'm trying to do my best in order to better and further the studies on oncology nursing. Of course, we have been communicating with the Turkish societies and also the international societies. I'm really happy to be here because there are different cooperations, and I'm introduced to different groups. As for Lösev, Lösev is a family that I'm a part of. Well, of course, this is just like a social family, and this is the first time that I'm experiencing this symposium, and this is quite a fruitful meeting for me. Today, I will be talking about national and international education opportunities for oncology nurses. My content won't be really heavy academic stuff. I'm just trying to create awareness for our nurses. How can I just improve myself? How can I just make use of national and international education? My purpose, my sole purpose, is to create awareness amongst our nurses. Can I change my slide? I cannot change my slide. Why do we need education? Of course, we've been discussing about why we need education. And of course, with the updating of the information, the outcomes of the treatment are better when we just update our information. But of course, there are the realities of life, and of course, our main purpose is to have better patient outcomes. And we have also legal obligations. And as the oncology nurses, we need to follow up the updates in our profession, and also we need to make sure that sometimes we need to change the treatment or the care of the patients. So we are obliged by, we should abide by the laws and regulations, and also we have the definitions and roles and definitions of the oncology nursing, and we have the general nursing and we have the oncology nursing, and oncology nursing has some additional obligations and duties, and so we need to meet the needs of the families of the patients, and this is a legal obligation. And how we can do it, we need to continue to improve ourselves and update ourselves with the current legalities and also responsibilities. Well, I cannot change my screen. Would you please help me out?
Teknik sorunlar her zaman olabiliyor. Umuyoruz tez zamanda çözümlenecek, evet.
And of course, when we look at the national opportunities, of course, our umbrella association is the oncology nursing association, and we have the vision, mission, and the targets. And of course, we want life learning education and training programs which should be disseminated, and so that we can update and improve the capabilities and skills of the oncology nurses. Well, I will just highlight the national education possibilities, and first there is a certificate program for the oncology nursing. We have the basic level oncology nursing courses, and also we have some specialized areas courses like palliative care, pediatric oncology, and gynec-oncology. And Ms. Fatma has mentioned about the certificate program of the association. They have different agreements with the private and public hospitals, and we have short-term courses that have been dealt with the private sector, universities, and public sector, and of course. We have had different courses, and in terms of participation to the association, there's a discount when you just apply for the membership to the association, and of course, the different institutions help their members to become a member of the oncology nursing association. And if there are some people who are not a member yet, please do apply to the Oncology Nursing Association in order to fulfill all the requirements and become a member as soon as possible, because this is an advantage for the international institutions. And you can just benefit from international programs free of charge. We have a YouTube channel. The YouTube channels are live. Some of them are live, and some of them are recorded, pre-recorded. And of course, I do strongly recommend that you follow all the programs on air on YouTube channel. not only the Oncology Nursing Association is giving certificates, but also the Ministry of Health is providing such certificates. And also there is the palliative care nursing certificate program. And this is a very valuable content as for the oncology patients. But not only the oncology patients are receiving palliative care, and these certificates are valid for 10 years. The oncology nursing is for 10 years, and the palliative care is for 5 years. And in the hospitals which are affiliated to the Ministry of Health could just give these certificates. You could just obtain them from the university hospitals, research hospitals, and also you might just attend to the program of the association. If you're living in a private hospital, or if you are just working in a public hospital, of course, the funds are sometimes a little bit, could be a challenge, because not all hospitals would like to invest in nursing certificate programs. But of course, you could just enter the certificate programs of the ministry free of charge. And of course, we have the theoretical education, and you can see the content of the education. Here we have another national Sanarkin. Sanarkin is also giving the certificates. We have the basic level oncology nursing, pediatric palliative care nursing, and palliative care nursing courses are available, and you can see and you can follow up from this website address. And especially these are given during the fall and spring. And as for the international education, international training opportunities, I would like to give you some examples in order to just create awareness. The European Oncology Nursing Association, and it's 2024-2028, they have prioritized 6 areas, and one of them is the priority area of training. And of course, in terms of the strategic priority area, of course, this is also aligned with our own association's targets. And of course, it is very important to receive those trainings so that we could have professionals solely working in the oncology department. And we have some targets, and there are some sub working committees, and there are some oncology nursing trainings which I'm going to be talking about. And we have the master classes for the oncology nurses. It started with the European Oncology Nursing Association. For the last 3 years, the European Oncology School has been very active. We have a joint and multidisciplinary project. And you can see that in 2022 there is a ESO masterclass in Seva, Barcelona, and Barcelona, Spain. And there was a great participation from Turkey as well. This year it's going to be in Italy, and I think there will be one nurse who will be attending to the Italy meeting. Of course, there are multidisciplinary joint ventures and joint sessions in the curriculum of this curriculum of this program. You don't have to pay for the training, the accommodation, transportation, and all the meals throughout the training is reimbursed by the European Oncology Nursing Association. And until last year, EONS was also reimbursing the transportation, but with the pandemic, unfortunately, this was reflected, the limitations were reflected on the budgets, and so they are not reimbursing transportation, but they are not really charging anyone for the training purposes, but they want everyone to pay for their own transportation. Maybe this is maybe they could just have a better budget, and they could just prepare the ground for more people to come with different transportation means. What are the application criteria to these trainings? You need to be working as an oncology nurse in the European Union. You need to have at least 3 years of experience, and of course you have to be involved directly in the care of the patient, and also in the management and organization of the cancer patient. You need to maybe you could ask this question whether academics could participate or not, but of course they are given the chance. But in the master classes, clinicians are given the priority because it's for the implementation in the clinics. So and to contribute to the development, personal development or the occupational development of these individuals, you need to have fluency in English. This is another criteria. But I'd like to tell you that okay, if you don't have any English, it's going to be a challenge, real challenge. But if you say that you can, if you can understand the person who is speaking to you, but if you cannot talk, please just get rid of this thought. Because language barrier is a great reality in front of us. But when you are a member to the groups, there are many people who have limited knowledge of English, but they are doing a great job. So please do not limit yourself and do not be scared in terms of the language barrier. You could just go there with a limited English knowledge, and you could do a lot of great things. And you need to be a member to EONS, and of course, when you're a member to our national association, then you are automatically a member to the EONS, and they pay annual tribute to EONS, and this is great an advantage. And apart from masterclass programs, we have been rendering these master classes for 3 years, and this was planned to be held in Macedonia, but of course it's much more easier for the nurses for transportation purposes. That's why we wanted to hold these meetings, and you can see the participants there to the 2021 Belgrade meeting. And of course, the training is free of charge. The application criteria are the same. For operational reasons, this was planned there. I'm just skipping some of the parts. And of course, there are also online trainings. Sometimes it's impossible for us to be physically there, physically present there, because throughout the pandemic we've seen it, we've experienced it in our own field as well. So the efficiency of the online trainings are debatable, but still in terms of accessibility, it's quite easy, and the online trainings for our own national association and for the international associations are a priority now. And of course, for the terminal cancer patients, there's going to be cancer training in 4 languages, and this will be open to everyone at the end of December. And of course, there is participation from the Turkish institutes and from diagnosis to the treatments to new to symptom management and care plan for the survivors and summertime and including all palliative care. And at the end of December, it's going to be a free of charge training, and you could just also receive certificate at the end of the training, and it's going to be an open source, and EONS will also announce, and you can easily follow them from EON's webpage. And for the research workshops, of course, it's as we have discussed in the morning sessions, the skills of it is for the development of the research skills of the nurses. There are two of them. One is a research proposal workshop, and the other one PhD research workshop. And there are 10 participants for each workshop, and they take turns. And training is free of charge, and all the expenses except the transportation is reimbursed by EONS. And when we look at the application criteria, for the research proposal workshop, the criteria is that you need to be working as a cancer nurse, and you need to have at least 1 year clinical experience. And also, these are for the clinical nurses working in the clinic. And of course, you need to have a master's degree, and you need English language literacy, and you need to be a part of the EOSN. Of course, you could just work with the consultants in terms of writing your dissertation proposal, but you need to have a good level of English, and you need to be a member of EOSN. And in the PhD research workshop, these are for the PhD fellows, and you could be at any stage of your PhD dissertation. And of course, with the consultants, you could just work on your doctorate thesis, and so that you might have a good format of your dissertation when you come back to your country. And these are some of the criteria which are quite similar. And this is the European Oncology School. As I have mentioned, this is an online platform. You could have live training sessions, and apart from these, you could see the ones today and for the future dates. And of course, you could have on-demand e-sessions, and you could have training videos. There are multiple topics that are being discussed. As I've mentioned, these are multidisciplinary titles. As you can see here, these are some of the keywords for search. For instance, when you look for palliative care, you could see a lot of online trainings, pre-recorded trainings, and you could find anything when you just write down the keyword for your research area, and you could just reach out to the training material. And last two well, it's not only about the training, but also bringing together corporations and collaborations. This is the global power of oncology nursing. This is they will become an association in the future, and this is the London Global Cancer Week celebrations. During that week, this platform was established. The main objective is to increase the impact of nurses on the outcomes of the cancer patients in the least developed countries and middle income countries. And we have a lot of representatives from Canada, America, China, and from many countries. You could just there is a WhatsApp group of GPON, and with the QR code you could just reach out to information on grants, especially for the developing countries and underdeveloped countries. And of course, as you can see in the slide, for instance, I need some training materials for X topic, and of course somebody just answered, and they said, okay, I need this training content, and many different sources are shared here. And last week I had an undergraduate student. I had a PhD student, and who completed, and she was looking for a postdoc in United States of America or Canada. And I just told her a few names, and I just recommended her to write this issue to the GPON. And when she wrote down her request, one of the professors from Canada contacted her, and now they started talking to each other. So I have a link, and I don't know how to just convey the link to you. I can just share it with you, and then we can proceed. But you can also use the QR code, and you can become a part of this group. And every year in November, as I'm a member of the steering committee, last year there was a talk on migration, and the nurses were represented in that conference about migration. This year we are going to be talking about the cancer patients treatment and care process in the earthquake zone, and this will be done by the representative from Osmaniye State Hospital. And of course there are good examples and good practices, best practices that we can share, and we are expecting you to our Congress in November. And I don't know whether you're aware of the European Union COST project. Please don't think it as a research program. COST is a platform where the academics come together and share best practices, and they can do a research together. So it's a collaborative effort of the European Union. And you don't need to be an academic, and there is no problem with English. You could only utter a few words in English. That will be enough for you. And of course, you could see the website, and when you just Google it, you could see, you could just reach to this page, and you could browse the actions. You could see the ongoing projects, live projects. And cancer survivors, for instance, digital-based care plan preparation for the cancer survivors. I've been in these committees, and you could just look for the subcommittees, and you can just you can see the projects, and you could, but you first of all you have to have a cost account, and after you just open up your account, you could just do the search and you can find the projects related to your interest area, and you could also demand to become a part of these projects. But of course, this budget is used for bringing together teams from different countries, and of course we have the academics and clinicians, as I have mentioned before. Well, I have been working in an institution which provides support to the researchers, but of course there could be some problems when you want to attend to the international conferences. But when you are a part of the COST project, when you are in the working groups, especially if you are under the age of 35, and because they do give support to the people who are at the beginning of their careers and about cancer. And if you wanted to just participate to the Congress, they can just support you. But especially for those who are under the age of 35, should just really evaluate this opportunity. But if you're not at the under the age of 35, there is no Congress participation support, but there are project meetings in different countries or workshops, and you can just attend to these workshops. And because we had a meeting in Ireland, we will have a meeting in Lithuania, and they do reimburse transportation and accommodation. Please feel free to make thank you. Thank you very much. If you have any questions, please feel free. If you just let me, I will speak till the first lights of the day. And of course, it has been really a real pleasure to listen to you. And of course, maybe you could just do the presentation in the National Association of the Oncology Nurses. Thank you. This has been a valuable presentation. We have learned a lot. Thank you very much. Thank you very much. I know that there will be questions, maybe one or two questions. I will leave some room for one or two questions, and if you have some questions, we could just receive the questions. Thank you very much.
Evet, Semra Hanım'ın bir sorusu var.
We have a question from Semra. It is not a question. I just want to say something. I'm from Ankara Oncology Hospital. I'm working in the education training unit, and in oncology department, especially in oncology nursing, we conduct many studies, and in total we are a large group in the hospital. And in this symposium, I can say that we have great content. I want to take the organizing committee for this. I want to say something about the international certificate program. As Ankara Oncology Hospital, we organize a certificate program at least twice every year. And also in the oncology nursing society we are working, and Ministry of Health has granted the authority to 3 places in Ankara, and there is also Izmir Tepecik Hospital, and in Bursa there is an oncology hospital. We are working together with 5 centers, and if there are participants from different provinces from Izmir or Bursa, I wanted to take the note of it. And every year we organize international oncology nursing conference. I want your participation. Thank you. For those who would like to prepare the presentation, you can send it by the end of October for this conference I talked about. Thank you very much. In this way, we have announced the activities in different countries. If there are any, we can have one more question. If not, we will directly continue with the next speaker. Thank you. Maybe if you want to contact me, you can find my email address. You can ask my email address. Please don't hesitate to contact. And if there is something you would like to share, I will share this. I am working as a representative. Thank you. Please do not hesitate to contact me. Thank you. Okay, we would like to thank you for this valuable information, and probably we will get together very soon and have a discussion about all these topics. And distinguished participants, now we will continue with the next speakers. We would like to first thank the organizing committee of this event. In this part, we will continue with the second presentation of this session. We will talk about sensitive approach and empathy towards oncology patients. Azizat Özbaş will make the presentation. Hello everyone, thank you very much. I want to thank you in the beginning of my presentation and also for this invitation. I would like to thank you. After Gülcan's presentation, I will not say anything you don't know. Actually, we all know those things. Sometimes we forget them, sometimes we neglect these topics, but it is an important issue. And we had a discussion with Nurşen, my colleague, about the title. And we thought about a loving approach or passionate, but we don't want to use it because it has compassion has some certain hierarchy. And for this reason, we decided to use sensitive approach. Our professional approach is important. Empathy is important for many things in our occupation. So in this presentation, I will try to tell you about our job and how should we do it, where should we stand, how should we approach. Nursing is a very complex occupation, to be honest. If you do it right, it is really complex. And it has many different components. It is like a puzzle, and in order to finish this, we need to have some skills, accountability, the trustworthy and independent, good communicators, fair, just, and reliable, scientific. These are all the components of being a good nurse. If we have a missing part, there's always a gap in this puzzle, and this is also reflected on ourselves and our care we gave to the patients. It is directly related to our occupation. It is directly related to our own personality and our occupational identity. As I said, it is really complex to become a good nurse, and to become a good caregiver, which is caregiving is, the essence of our job. We need to be empathic, and we need to be competent. We need to be reliable, coherent, and effective communication is really important. We need to support the human dignity, and we should do this in cooperation and with respect to those patients. Of course, I'm not I'm a psychiatric lecturer, but communication is at the basis of everything. So this is actually your reflection of what you do to the other person. So you can convey this message by your communication skills. So it is actually the window, main front page of a nurse. Communication is the front page of a nurse, coverage of a nurse. Have you ever went to kitchen appliances, went to buy kitchen appliances? You know, it is really, prices are skyrocketing. We're not able to go, we don't want to go buy kitchen appliances. We're just opening its lid and close it again, like a washing machine, think about it. And it is quite limited, but what can we understand by just doing this? But people are doing that in evaluating you. They don't care whether you are very attentive, very careful about asepsia, your scientific information. They don't have any capabilities to measure your scientific skills and abilities. They can only evaluate your oral or verbal communication or gestures and your body language. When I'm saying communication, it's not just the words coming out of your mouth, your attitude, your moves, your movements. This is how the patients are evaluating us. Actually, to be honest, even our colleagues are evaluating this in this way. And when we are talking about communication, when I say sensitive communication, it is also important for our communication between different colleagues. With our colleagues, we need to have a sensitive approach. How it is decisive for you. You can feel yourself better when you have a better communication with your colleagues in the workplace. In studies conducted, it is demonstrated that financial conditions are important, yes, but this motivation by financial conditions are continue only for 6 months. But if you have good communication with your colleagues, if you have a good sociable, if you are quite sociable, if you have good social activities, these are the best protective measures against burnout. And at the basis of this, we can see that there is communication. Then we have occupational integrity. It is I'm not just talking about being a good nurse. These are the components of being a nurse. When we have all these components, then we can talk about an integrity, occupational integrity. If it is partial, then your life will be partial, and you will continue your life with this feeling of shortcoming, and you feel like you do not belong to this place. You do not own this place, own this job. So occupational integrity is really important, and those people who have their occupational integrity are doing the right thing in terms of ethics, and in terms of capacity and ethics. They are developing themselves, they attach importance to themselves and also their own occupational skills and abilities, and they continue their job as a whole with an integrity. What am I talking about this? Because I'm trying to get to some points. I want you to ask this question to yourself. What are your values? What do you believe in? And what is the most important values for you? Especially, what are your values when you're doing your job? And how do you give meaning to your job? It is really important. And I studied psychological strengthening in oncological nurses. And the first step of strengthening is giving it a meaning. If you give it a meaning, if you can say that I'm doing something meaningful, I'm touching people's lives, you feel better. If you think that I'm coming to a job, coming to work, I'm doing the same thing, it doesn't make anything, it doesn't change anything, I have no effect, then you feel bad, and you don't feel good about your job. And if you say that I come every day, I do the same thing every day, I'm just giving care to patients, there is nothing I can do, they are all I'm losing those patients, then this means that you are missing out the meaning of your job. So oncological nurses are the most advantageous group in giving their job, occupation, and meaning, because you're with them in their most important moments, and we are touching their lives. Because actually, I shouldn't tell you this, you're working in children oncology, and I believe that most of you are working with children, and your way of giving a meaning to your job is important. So how this job is serving your personal projects, what is your reference point? So what I mean by that, I will explain. What is your reference point for you to feel better about your job? What is what your neighbor says, for example, or what TV says about your job? And how in line with your, how is this reference point in line with your values, or professional values are also important. Professional values or your own values is another question. What are your reference points in your actions? Action is one of the most important things in the occupational integrity. And what are your reference points when you're deciding upon doing something or not doing something? But these are important because these are decisive upon your communication skills, or the way you communicate. And when at school, so we are focusing on some techniques, some perspectives, or some reactions, and what would be the effect of these actions. We are providing trainings. But when we look at the basis of this, if the person is intended to learn this, they will learn it. If we listen to the person across us, if we listen to each other, we can understand them. We have Rumi, Mevlana. He says that heart is the sea and tongue is the shore. Whatever is in the heart will come ashore, come to the tongue, because it is the shore. So this is important. If you feel that, if you think that you are unimportant, you will be invisible there. If you believe in the importance of what you do, if you think that you can change something, you will get in touch with the patient. And if you think that the patient is hierarchically inferior to you, your body language will be like that, and your attitude will be like that. So you need to be very, very careful about those questions, and we need to try to give an answer to those questions I just showed you. I found a survival guide. It is simple. There are simple items. This was from Smith's book about caregiving and how the nursing should continue. There are parameters, and we can talk about 20 items. And when we look at all these items, you can realize that they are related to communication. And patient safety is the main issue here, is the essence here. And it is not just about the people you provide care. The communication with your colleagues is also important. As long as you have this good communication, you will be able to solve your issues about your patient. And I'm working on moral distress with one of my students. Moral distress is about doing something which is not in line with your own values. For example, a participant says that in the team there was a discussion, argument, and the nurses and the other healthcare professionals were separated, and none of them are talking to each other. There is no communication. They separated their tea corners, and then the patient is the loser here. The care quality is affected negatively. but the most important damage is, of course, directly to the patient. So when we're talking about communication, we're only thinking about patient and the relatives of the patient. Sometimes when we think about this, we've talk about this. They say that yes, I understand the patient, but what is happening to the relatives of the patient? The study says that the anxiety, depression, harmonization problems are in directly parallel to the patient's situation. Patient's relative is in a crisis too. And it is not just with the patient and patient relatives. We should also add the colleagues in this equation. And in these kind of cases, there are some questions from the participants. You say that, why should we always understand? Why should we always be the one who is understanding? So sometimes you say that the patients and the patient relatives should also understand us. Yes, we are working in hard conditions, but we are trained to work. We are the professionals. We are trained to work in this field. So the responsibility of communication management is on our shoulders. Being attentive, being kind, listening to people. These are important principles of providing the nursing care, and we need to provide those people to what they need to know. We need to provide this information to them, and we need a good communication to convey the main problem to the patients. We need a good communication for non-discrimination, and we should communicate with the other responsible authorities, and we should make sure that the care is still continuing. We should be we should be reliable. These are all the main values of nursing, and these are all directly related to the accountability, which is one of the main part of being a nurse. So compassion, I talked about this. There was a book, and in Oxford Dictionary it says that being amicable, being understanding, being merciful, and being prone to be helpful. I don't know which word can be used in Turkey. In Turkey, they have this white angel symbol in our occupation, and sometimes we have some concerns about it negatively affecting our occupation, but basically we can say that being prone to be helpful. And I totally believe that we have a nature of helping as a person. It doesn't matter whether it's from our kind or not. We want to help those people who are in distress. We should not use this, and I think it will suffice. How can we do this? We try to understand how can this person would feel. How can this person feel? And we should be very sensitive. We should be very attentive. Careful. If this person is an elderly, disabled, sometimes we directly go into the room and directly communicate with their family, with their father, parents. We do that very careful, very frequently. And the children, for the elderly, sometimes we're talking with their children. And now the children take the role of their becoming parents of their own parents, and we should be sensitive to their needs, capacity, and communication is important, care is important. We should attach importance to them, and we should have an effective communication with them. However, to become compassionate, we need to understand the needs of the person, and if we do not do that, we neglect the person, and we totally say that I know what you need better than you. I know what is good for you better than you. But what can we do to understand the person? Empathy. And this is the point where empathy comes in the equation. We all know about empathy, but at some points we have some hard time understanding it. We are working with standard patients in Hacettepe. The patient is quite angry. The student is going in and they understand that he is angry. But what they should do? There are no problem about first two steps of the empathy. We will put ourselves in their shoes. We try to make an evaluation with their perspective and try to understand their feelings and thoughts in the correct way. We will try, of course. It is not possible to do this all the time. Sometimes existential approach, for example, says that it is not possible to reach empathy. You cannot understand another people's feelings. Everyone is a different world, and we don't have such a privilege to understand the inner world of another person, they say. But we try to do it as much as possible. For those first, I'm sorry to interrupt you. You have already completed your time. Without saying this and without making this person say and without confirming it, we cannot finish this. We need to say, I see you're a little bit angry today. Okay, what should we do later? Okay, the patient said that yes, I am angry or yes, I am sad. So what are we going to do at this point? David Kusanen has a communication book, and there are steps recommended in this book. I just took the part about empathy. It says that confirm and normalize it. So for example, there are many other patients who are in your situations, and they are also experiencing these kind of things. Make it valid. The second step, the second part. Yes, you have reasons to be sad. I accepted the feeling, I normalized it, I validated it, and then can you tell me about your sadness, your anger? Can you tell me what is making you fierce? And then appreciate their effort. You are going through a very hard phase, you are going through challenging days, and this is a great effort for you to even come and talk to me about this. So once I empathize with them, this is the most important point. When we do this, at least we will have a shortened distance. The longest distance is not in Africa, is not China, India, or the nights or the stars. It is the distance between two people who are not understanding each other. So why are these things important? We are trying to increase the quality of the care we provide. We try to decrease the complications. Malpractice cases are decreased, and repetitive applications are decreased. And you are not burnout. You don't have a burnout, and you are strengthened. In almost all strengthening studies, we have a communication session. It is really important. It is something we can use like a medical tool. If you are aware of this, I think we will be more successful in communication. Thank you very much for this great presentation. And if there is a comment or question, we can collect them. I think there is a question. Dr. Akan from Children Hematology Oncology Service, thank you very much for this presentation. It was a great topic, and you talked about very important issues. It's not just the case for the nurses, it is also the case for all healthcare officials, and what you underlined are also important for the physicians too. Well, of course, when it comes to practice, things become different, and For example, in children hematology oncology service, if there is a night nurse who is working in this department, they take care of 10 patients in a state hospital. So things are changing at this point. I don't want to talk about the details of it. Of course, no one needs to do this, but I would like to thank you very much. This was a good presentation. Thank you. We can have another question or comment. What you just said is important, and in the studies conducted, we also see that this is the first thing that is mentioned: time constraints and burden on their shoulders. The patient has an anxiety, and you realize, or maybe you do not realize, if you do it, the patient is coming to you 10 times until morning. But if you just separate, if you just give the patient 2-3 minutes, then things will get better for the patient. And I want to say one thing. This just happened in this month in İzmir State Hospital Emergency Service in Ankara. Maybe when they are informing the patients, the other nurses say that, why are you talking to patients? Because now they will expect all the other nurses to talk to patients. So this is so sad. I worked in clinic for 10 years, and they were saying that you've been working here for 10 years and you're acting as if you have just graduated. I took it as a good comment, as a compliment. It's a good coping method. I think we have time for another question. We will see if there are any. I want to thank for this great presentation, and I want to give an answer to this question. Are the patients, do the patients need to understand us? But not in the beginning, but if we approach them within if we share them, when they see that, we share them our time, we give them our time, they understand us too. I've been working with hematology and oncology patients. Yes, I am very busy, but I see the anxiety of the patient, the concern of the patient. I say that I am very busy right now. After that, I will come to you, I will tell you something, and I understand your concerns. Then they know that I will go and tell them. So they become calmer. So telling something is important. You don't delay something, because you will this will take more of your time if you delay something. We can understand each other, but we need to understand the reasons of those crises. And in my doctorate thesis, I studied logotherapy. And when I was receiving this training, I was working in hematology. I started my practice, and a patient relative, the patient was a candidate of a bone marrow transplantation for third time, but for 3 months he was in the hospital, and his sister is taking care of it. Her sister is 65 years old. And as the primary relative, they were there, and I heard some voices, sounds, and they were the patient. Her sister was screaming and yelling at the patient, and her sister said that he is not eating. But I understand from these talks, I realize that she is helpless. Her sister is helpless. She is trying to save her sisters, and she is not able to do this. This is how she directed her anger, and I said that death is inevitable. I don't know which one of us will die or which one will not, and you're doing what you can do. This should be appreciated, and women felt better. And I went to the patient and I said that, why don't you want to eat? And yes, they don't have the power to get out of the bed. Okay, but why don't you move? And she said that I don't want to move. And when they stay in the hospital for a long time, you know all the family members of this patient. And I know the life story of this patient. And I told the patient that I knew that you were a very courageous person. This process might end with being. Can you please wrap it up, because we have another session? And then she started eating. Good communication. When we have good communication, we can understand the patients and we can see that respect from the patients too. Thank you for your presentation. Thank you. Thank you very much. And thank you for this good presentation.
Well, we have a presenter from another country, from a foreign country, and we will have Nikolina Dodlek, and she has been working on oncology nursing, both in the field, both in the academic world. She is a researcher and a nurse. She is participating from Croatia, and Nikolina has worked in the field. Then she has completed her master's degree, and now she has been a PhD dissertation. She has been a PhD student, and also she is a member of EONS. She's active, especially a member of the Young Nurses Committee, and she is also active in terms of empowerment of the oncology nursing in her country. And now she will be talking about the resilience of the oncology nurses, and I'd like to invite her to the floor. I think we've got the connection. Yes, please. You have the floor, Nikolina.
I would like to thank the organizers for inviting me and for making it possible to me to present hybrid. So yeah, I have been introduced. I'm an oncology nurse from Croatia. I've been working in field of oncology for 14 years now, and I also teach in Cathedra for palliative care and nursing. And today I'm going to present a short presentation about psychological resilience of oncology nurses. Is everything okay with the slides? Okay, I have no conflict of interest to declare. As a field of oncology and hematology is really sensitive branch of nursing and healthcare professionals. We have heard in previous sessions how important is compassion. I wanted to present you just a couple of models and figures about compassion and how can compassion lead to compassion fatigue. How compassion fatigue and compassion satisfaction actually can really impact the quality of life, both personal and in professional field, because in oncology and hematology wards, nurses have to have a special ability, a special empathy, but also take care of being exposed to burnout because of own state of physical and both mental well-being. Another model was a Figley model that was also impacted on the model of caregivers, explaining the compassion fatigue as process of being exposed for some kind of empathic concerns, whether it's from our colleagues, healthcare professionals, whether it is from the patients or patient families, especially with young children or adolescents and young adults. And that prolonged exposure to compassion stress can lead to compassion fatigue and the life disruptions. So compassion is described actually as an ability to have pity or the urgent desire to help or to aid someone. And also you hear in the airplanes, take and have your own mask first before you help someone else. Perhaps it sounds a bit of strange or difficult, but if we are not able to cope with ourselves and do the self-care, how will we be able to cope for our patient? To have compassion and empathy for our colleagues, our workplace, private and professional relationships. So those risk factors that can impact us can be both internal and external. External, of course, rely on our workload, on working long hours, difficult shifts in different work settings, while internal, they are more related to our current mental and physical status and our physical and spiritual well-being, because not at every moment of our life we are able to cope with different and difficult situations equally. So Squirrels has described in 2016 5 stages of compassion fatigue, which is really something we can see as a model of young oncology nurses. First phase is usually the zealot phase. When we are enthusiastic, we have just started our work in oncology or hematology department. We are willing to input extra hours to educate ourselves, to jump for our colleagues, or perhaps to be here for our patients. But if we are exposed for a long time to that kind of situations, sometimes we can notice that colleagues sometimes take shortcuts. That phase is called irritability phase. Shortcuts in a sense of perhaps if we have a difficult or critical patient, colleagues take shortcuts of not going to that room, or perhaps avoid speaking about the issue or speaking about difficulties at the department, which can lead to either overreacting, either to withdrawal phase, which is not good because in that phases our enthusiasm is gone. So it can lead to losing our compassion, or even like we experienced in COVID, how many nurses have left the profession due to burnout. So it's really important to have both personal and professional support. We like to call it accountability buddy to set a SMART goals. Most often for us, it is a buddy at our workplace. It is a colleague who is here for us and supporting us. We set SMART goals to be specific, to be measurable, to set it to be realistic. We have to set it to be time-based. And our body is here to remind us from time to time, hey, have you been doing this or that? Or how are you feeling today? Or do you still feel exhausted or tired? Or so important is to have self-compassion, to be less critical to us. Sometimes we don't know what to say, perhaps for a difficult ill patient or patient who is in pain till his painkillers don't start to kick in, or we shouldn't be critical. We should be self-kind and have a sense of humanity to ourselves. Sometimes we feel like useless because we didn't know how to make the conversation with that person, and we all need the mindfulness. We shouldn't hold in our thoughts. We should express our feelings. Not all of us are extrovert persons. Perhaps someone is introvert and copes with difficult situations in different way. So there are some stages of self-care, not only physical, like being active, walking, listening to the music, eating healthy, but also emotional, both mental, social, with social support from our friends and our colleagues at work, also spiritual, religious, financial, professional as education, and both environmental. So the key is problem solving and seeking social support, which we have been experienced a lot with young hematology and oncology nurses. As often as mentors, it's not a shame or be afraid to show your emotions or to say, I don't know what to say to that patient, or when I come home, I think about situations what happened at work. I think we should discuss it as a team at work to have some kind of perhaps team briefing or during the shift handover, because that is crucial also to have a better patient outcomes. So as Dr. Bakivan already mentioned, that European Oncology Nursing Society has quite a few free webinars on EON's YouTube channel. So Young Cancer Nurses Network has chosen the themes that tackle them the most. And one of them is compassion fatigue, burnout, because not all of us undergo resilience program before we start work at oncology ward. So please feel free to go to the YouTube channel and listen to it, although they are in English. But also stress at work can come from a knowledge. There is a lot of chemotherapy, immunotherapy protocols, a lot of side effect management. So also, while the time we educate ourselves and how to help a patient and how to do the protocol and symptom management, we can also feel compassion fatigue and stress. So we are also inviting you perhaps try to educate, because for instance, safety webinars are in 6 different languages and are also on the EON's YouTube channel. So please feel free, because teams are also identified by the most issues that cancer nurses are facing. Building resilience and mission and vision is to try to identify, especially starting from our workplace, whether it is clinical or academical or it's remote patient monitoring, to identify everyday challenges and together to develop strategies to overcome those barriers, because it impacts highly not only our professional but also our personal lives. So in different kinds of ways that Dr. Bakivan already mentioned, as educational grants, as networking, as different kinds of events, like EONS, European Oncology Nursing Society, consists from different working groups, but I wanted to emphasize that acronym is CARE, that together we care. We care for each other, we care at our workplace, we care through national societies, through European societies. I wanted to share that I'm very proud to be part of Young Cancer Nurses Network in EONS, and it is also a fabulous opportunity, and we invite you to join us. Come and visit EONS webpage, because it's an amazing community where we exchange experience, we share knowledge and expertise with each other. And yeah, please feel free to visit, because like Maslow said, a pyramid has 5 stages, and one of those is need for belonging somewhere. When you feel that you belong to that team and you belong to that workplace, that you belong to oncology or hematology ward, it's really something that gives you the empowerment. So crucial is also a mentorship. Before I was mentoring, I was also being a mentor, and it can be both clinical and academical mentor. We all have role models at work, role models among professors, among doctors, among each other, but also it's important to have a friend mentor, someone who will be there to support you. The unmet needs. In the beginning of our career, especially, we were really not free enough to ask if people are okay, if it's okay to discuss some difficult situation at work, perhaps some terminally ill child, or if it's okay to ask someone else. Not everyone feels comfortable sharing. So ask your colleague at the end of his night shift, how was your shift? Was it difficult? How was that patient? Please go and rest, or ask yourself, do you also need support? It's okay to ask. It's okay to communicate. So also, as Dr. Bakivan mentioned, a lot of educational activities will help us cope and build resilience, because we will feel more secure, more empowered when we receive training. Evidence-based has shown that receiving training has really better coping with difficult situations. So some of our examples here in oncology wards are that we do not have resilience training, but we have psychologist, which is available not only for patients, but both for the staff, for nurses and healthcare professionals. And it really means means a lot, whether it's going to be an individual session or it's going to be a group therapy. So we can always try to implement that. Who can help? There is actually a lot of ways of help. We just need to ask. We start at our workplace. If it's not a toxic environment, if it's one healthy environment, ask help from a colleague, ask for help from your manager. Of course, there is also a private life, a friends, a family, or partner, although we cannot very often hear how, if they're not healthcare professionals, they don't really understand, or we don't want to burden them. Also, it's okay to ask an expert, a local or regional association, national society, but both European organizations. So you see, there is really a lot of ways to seek help and also to provide help to each other. We often can come to some barriers to support. Mostly it is lack of the time or some kind of bad management. We are in fear, we are in stress not to say something wrong, or how to ask the question, or saying that we do not know something and do not know how to cope or what to say to a patient in this situation. But what can we do? We should work on eliminating burnout, to support each other, to remember how was it for us, especially in the beginnings. How did we learn to cope with difficult situations? How many times did we bring home thoughts about patients, about parents of a child, or even stayed in touch? So we should respect each other. Firstly, respect each other's role in the team at work, and try to do retention and build up career satisfaction. So because preventing burnout highly impacts improving standards of patient care. Sometimes working long hours, not only in clinical direct care, but also as a researcher, as educator and mentor, can lead to psychological and physical exhaustion. And then you feel you're not really effective. Can you even support and provide what the patient needs, what the colleague needs? It's very important to implement positive psychology. No matter how difficult sometimes it seems, it always works. We need to start somewhere. So integrate it in our workplaces, integrate it in our private lives, to build up the community on the local and also on the national level, to promote empowerment. And also it's important to recognize each other's values, each other roles and places in our teams. So resilience is the key. Try to implement it and integrate it, not only our workplace, but also a personal life. For someone, resilience and coping with difficult situations will be listening to the music, doing religious ceremonies, dedicating to the family, dedicating to our children, spending time with them. For someone else, perhaps that is going to be some education or speaking to a colleague. But we should start from our workplaces, from places we spend quite a lot amount of our time daily. So it should be one healthy environment where we will feel good. Self-care is also one of the keys to acknowledge that we want and need a self-care, holistic approach, team strength, social support, and have the debriefing. No matter how much busy we are, it should be good, if not in the shift handover, to have at least weekly debriefings, meetings, or on a monthly basis. We all know we're not eager to come to our workplace if we are on our day off, but it's something that is crucial to discuss what is happening, to discuss difficult situations or good situations, to give some examples, perhaps the unit manager to our team lead, and debrief with our colleagues, because very often a miscommunication can occur because we do not express our emotions and feelings as well. And some take-home messages: help, support, and empower, because resilience is the key. And please also take care of those young nurses starting at oncology and hematology wards. They're really special and sensitive group of nurses who need our support. We all need support. And I'm happy that I could be with you here today. And if anything is needed, please feel free to reach me through email. Thank you once more to the organizers for providing me opportunity. Good luck with your work.
Kole'ye çok teşekkür ediyoruz değerli sunumu için.
We would like to thank for your great presentation. Are there any questions to her? There is simultaneous interpretation, and you can ask your questions to her in Turkish. It will be interpreted to English.
First of all, for your nice presentation. I feel that burnout is a very important risk situation for the staff. It causes a great turnover of the staff as well. My question is, supervision is the most important supportive issue for the nurses and as well as the administrative staff. But I would like to know that in your institute, whether if there is a supervision support for the nurses as well as psychological and oncological education for the caregivers, families. Thank you.
Thank you very much for your question. No, unfortunately, there is not official education on side of psychology, but parents and caregivers are free to have individualized sessions with our psychologists. There isn't something that is a group training, but every parent or caregiver of a child or adolescent and young adults is, I don't want to say obligatory, but it's one of the steps within the treatment to visit a psychologist, not only the patient, but also the caregiver. So it's not kind of a group training, but it's an individualized support and one-to-one talk, which can occur while the treatment is ongoing. So you can have as many sessions as you need or feel you need.
Çok teşekkür ediyoruz.
Thank you very much. Any other questions? Okay, I think not. We would like to thank you, Ms. Dodley. This was a very important topic in terms of oncologic nurses, the resilience and strengthening of the psychological resilience is really important, and it has different aspects, and it is also reflected to the care of the patient and also our own personal care. These are really important topics, as you said. Hopefully, we will have more studies about this, and currently, there are many different activities ongoing. And in Turkey, we are starting to support the patients and the teams. Sometimes there are challenges in the practice, but hopefully in time, we will make everything better for the nurses and the patients and families, and we will make everything better for all three legs of the system. Thank you very much for mentioning this very valuable topic.
I wish you a nice rest of the conference. Thank you.
Çalışma sunumlarını yapmak üzere.
Now we will continue with Gizem Göllü. She will make a presentation about a single-center study by LÖSANTE Hospital. Firstly, I would like to welcome you all. We talked about empathy, burnout, and as an oncology nurse, I decided to make a study, and I lost a patient, and I had a collapse, emotional collapse after the loss of this patient, and I'm still feeling bad for talking about this. And then I realized the nurses are also affected in this way, and other healthcare professionals are also like that. And we should this should have a name in the literature and make a search. I searched it, and it is emotional contagion. And I wanted to make a study about this. When we are working in hematology oncology, we are under an emotional burden, and for a long time, when they stay in the hospital for a long time, we have a connection with them. We understand what they feel. They understand what we feel. And this is affecting the whole team. So I wanted to talk about care. Care means nursing. Nursing means care. So I wanted to check whether emotional feelings have some impact on the care actions. And we need to understand the patients. In hematology oncology clinics, we try to understand the levels of emotional contagion, and I wanted to compare this with the other departments. I already talked about the aim of the research. So I want to say that there is not much research about contagion, emotional contagion. There was a dissertation, the doctorate dissertation, and they focused on the organizational results of the contagion, emotional contagion. There are many studies about care, but we don't have a research in which two of them are brought together. So what is emotional contagion? We are impacted by other feelings, emotions. Turkish society can convey the emotions to other people, and as the people who are in the hospital, we are exposed to many different types of emotions and expressions, body language, gestures, mimics. These are all leading us to understand the emotion, and they can, even without saying good morning to you, the patient can understand, or you can understand, the emotional status of the patient. So this emotional contagion is really important for us. There are hints of emotions. We understand them instantly, and we capture those emotions. And we experience those emotions, feelings, and these emotions, they say, are contagious as the diseases are. So sometimes when a person is crying in front of us, we want to cry. And sometimes when a person smiles or laughs in front of us, we want to laugh too. So this is contagious in a sense. We need to be aware of this to begin with. We need to understand that there might be a possibility of emotional contagion, and we should act according to this. The patients should know that, the physicians should know that there might be contagion, and we can give the care in accordance with this, of course, this contagion is affected by individual characteristics and the relations between different people. And in women, it is higher when compared with men, and extroverts experience more emotional contagion when compared to introverts. And we can see that social norms are also effective here. Large organizational groups can be an important place for emotional contagion. You can a single event can affect the whole hospital, or the whole board of the hospital. So we need to understand this. We are working with people, and nursing has taken its basis on human care, and care is important in terms of the wellness and improving the wellness of the patients. During the caring process, nurses are helping the patients. The patients are sharing their feelings and emotions with the nurses, and of course the quality of the nursing care is really important. And you all know about these things. I don't want to read this. This is the definition of American Nursing Society for the quality of nursing care. And we compared the contagion, the emotional contagion of the other departments' nurses and the oncological nurses. We had approval from ethical board, and we had 260 nurses. We use Kruskal-Wallis test and Whitney-U test, and we had correlation test analysis between different variables. And what is the emotional contagion scale? We use this Doherty scale, and for both scales we used 5 Likert, and we looked at 15 items, and it is 5 Likert type, and 50, if it is 15, contagion, emotional contagion is lower. If it is 75, contagion is higher. The Cronbach alpha number of the scale is 0.9, and in our study it is 0.8, and reverse coded, there are no reverse coded questions. So this is the emotional contagion scale. We have negative and positive emotions. We have these questions about positive emotions in 2, 3, 6, 9, 11, and 12, and the other ones are more related to olumsuz emotions. When we look at the scale of care behaviors, it is developed by Wolf et al., and we have the reliability in check by Gül and Dinch. And there are 3 items, and there are 3 sub-dimensions. And if it is 30, it is lower. If it is 180, it is there is really high emotional contagion. We use in our study, Cronbach number was 0.96. There are 3 different subgroups respected towards other people, professional information and attitude, and being accessible for the individual. And you can see the question numbers which are related to the respect towards others. And you can see the defining data. The number of women is higher, number of singles are higher, and most of them have 1 child. Most of them have been working for between up to 3 years, and we have different working places, and they work between 45 and 55 hours. And you can see now the averages of the scales. And when we look at this emotional contagion, the maximum is 73, and for care behaviors it is 180. The maximum is 180, but average is 165. This high averages shows us that contagion, emotional contagion, is high. We looked at gender variables. There is something like that in the literature. They say that women are more exposed to emotional contagion, and this study is also confirming this, and they are exposed to more emotional contagion in terms of negative feelings, negative emotions. And this is supporting the previous literature. There are 2 different age variables. As the age is increasing, negative emotions exposure is increasing, and the nurses, as they age, become more vulnerable in terms of emotional contagion, and this might cause because of motivation, lack of motivation. Let's look at these both groups. There is an analysis here, and you can see the subgroups of 2 scale. We made a comparison based on that, and we have positive emotions and negative emotions subgroups. And there is respect towards other, professional information and attitude, and being accessible to the individual. So they have some relations. If the person has positive emotional contagion, then their care attitude is affected. And when we look at the emotional contagion scale points, these points related to being accessible to the individual has been meaningfully increased. So as this levels of contagion is increased, the care understanding, care perception is changing for the nurses and the patient. Let's look at hematology and oncology nurses. We have negative and positive emotions, and we have emotional contagion scale. And then we see that there is a meaningful relation between them. We can say that these hematology oncology nurses are highly exposed to this contagion of emotions. As this is increasing, they have their care perspectives are improved. But when we look at the other nurses, we have positive emotions. We have the highest correlation in positive emotions. In the other nurses, as the contagion is increasing, there is not much change in terms of caring, and this is very different in hematology oncology nurses. Now I want to share the recommendations. The nurses are mostly in the hospitals, and they are responsible for the patient care, and we need to understand what kind of things are affecting their services. And the control of the emotions are really important in the attitude of the nurses. They should have the empathy capability. They are working in a hospital, which is very stressed place, and this is bringing physical and mental burden. This sometimes causes some problems in terms of the quality of the care, and this is a great cost for the hospitals and the society. So we need to increase their capacity to manage their feelings, emotions, and we should provide trainings to them, and we should provide better conditions for the nurses in the workplace, and they need to understand what they are feeling when they are giving care to the patients, and they need to be aware of this emotional contagion. These are the resources. I left my 2-month-old baby to come here, and there is nothing we cannot do if we want to. Thank you very much. Thank you very much for being here. We want to thank you, Gizem. By the way, I was one of your students. Yes, she was my student. I am very proud of you. I want to ask a question. This is a good study and very impressive results. I don't know how are you going to reflect this to the hospital policies. In our hospital, we are highly supported in terms of training. Maybe you have seen this. And as I'm a psychiatry nurse, I am trying to help those nurses, my colleagues, and we have the society and working together with the doctors, physicians, and we try to find the gaps in the field, and we're providing trainings, on-site trainings, because hematology and oncology is a difficult branch in terms of clinical knowledge, and psychologically managing this process is also really hard, and even a look of a patient of a nurse can change the feelings of the patient. So we are trying to change their attitude towards patients. We are trying to correct these issues instantly. We have some on-site in-service trainings. what is important here is to be able to implement the scientific studies and the clinic. We have highly exceeded the time of this session, but maybe we can have a question from this. Hello, thank you very much. I would like to congratulate you, and we're really happy to see these kind of studies in the clinics. Before you started the presentation, I want to say something. Mourning, occupational mourning, it is also something we can use, and when you lose a family member, it is acknowledged, recognized by the people around you. But when you lose a patient as a nurse, then it is not recognized. We had a study about this, and maybe you can check this out too. Thank you very much. Thank you for your recommendation. Okay. And now, this is the end of the third session of our symposium. We would like to invite all the participants or the presenters to the stage to receive their certificates. In the morning session, we already talked about it, so I wanted to repeat that because this is a very meaningful attempt, meaningful study. LÖSANTE will plant a seedling in the name of the participants to Seferihisar Natural Farm, and I want to repeat this and share this with you. Thank you.
For the second session in the afternoon, I would like to invite Ziyafet Uğurlu from Başkent University and from Hacettepe University, Nilay Aydoğan, to the floor to co-chair the session. Thank you very much. This is the last session of the symposium, and first of all, we'd like to thank all the participants who have participated, who have left, and I'd like to thank to the distinguished executive board members for holding such a beneficial symposium. And the last session is about safe drug implementations and patient safety. And of course, we need to have a better and safe management of the drug implementations and applications. And now I would like to invite from Hacettepe University Associate Professor Imatullah Akyar to the floor for the first presentation. Please, you have the floor. Thank you very much. I'm really happy that I'm here with you, and I'd like to thank for the kind invitation of the organizing committee. And of course, I will be talking about medicine administration, and as we have been discussing with our professors, we have become an unsafe society in terms of the use of medicines, and we are exposed to different information, and we are quite suspicious of the information, and of course we need more and more safety implementations, and we have a lot of questions to ask about whom to trust to, and of course we are trying to create a safe environment, and I will be talking about the safe drug implementation, and what are the guidelines, what are the updates of the international organizations in terms of guidelines. Of course, I will be talking about patient safety and also the health worker safety. Of course, we are focusing on the patients mostly. When we talk about safe medicine implementation, of course, we could have a different level or dimension, just focusing on the patient safety and also the health personnel safety. When we talk about the oncology nursing roles and responsibilities, we have great many roles in terms of managing the symptoms and also early diagnosis, and of course we have pharmacological and non-pharmacological implementations, and of course we have different roles and responsibility in terms of taking care of these patients. And as we look at the oncology, European oncology nursing standards, of course, it's the care to be given to the cancer patients in a safe fashion. And what is the safe treatment, what is the safe medicine implementation. Of course, this is a wide spectrum. And when we talk about all of the medicine, from supply demand to safely store them, transfer, and also then the implementation phase, we need to have safe steps in each and every stage. Why for the breast cancer? And in 2015, 49-year-old male patient has lost his life with high dosage of chemotherapy. And so this patient has lost his life. Then the institutions explored what went wrong, and they had thought about safe ways of administering these medicine. 63% of the nurses have told that they have made mistakes while administering the drugs. And right at the same time, every one patient out of four patients, we could prevent such practices. And of course, there is an EOS safety statement in 2019, and out of 10 patients, one patient is harmed. And if this patient, if we talk about the oncology departments, 3 of the patients are harmed, and 15% of the healthcare expenditures are wasted. Why this is important? And this is important because we need to just mitigate the risk, and we need to also be careful in terms of administering these medicine. And of course, sometimes we change the doses, and such wrong dosage administration should be avoided, and we could just see this in every institution almost. We are talking about 140 medicinal mistakes. There could be dosage mistakes, or the duration could be wrongful, and maybe also administering the wrong drug to the wrong patient, and infusion rates could be wrong, and wrong preparation of the medicine, and wrong treatment to the wrong patient. These are some of the common mistakes that we come across, and of course these should be taken into consideration in order to decrease the number of wrong applications. Because the cancer treatment is a complex process, and the risk is higher than any other. The risks are higher, and we have laboratory parameters that we need to take into consideration, and of course we need to follow up the liver enzymes. And here we have some evidence-based applications, and of course these guidelines can help us. And when we just evaluate the guideline. This is the ASCO ONS American Clinical Oncology Union, and there are 4 different titles that we can just dive into these standards. We have safe chemotherapy administration standards. We have oncology medical home standards, and these are this is the updated American Society of Clinical Oncology, which happened right afterwards the death of the journalist. This happened in 2008 for the first time, and this is when we look at the date of the guideline. And in 2009, the Oncology Nurses Union prepared the standards for the first time and published them for the first time. And in 2011, this was updated for the clinics, and 2013 this was also updated for oral antineoplastic medicine, and in 2004 the pediatric patients. This was taken into this guideline for the first time in 2016. And of course, I won't get into details. There are 4 main branches of safe medicine implementation. This also guides the institutional charter. These are some, and also the complications and toxicity should also be followed up. These are the procedures, and these procedures are patient care registration, documentation, process, policies, and procedures. So all of them should be followed up closely. And if you look at the chemotherapy policy document, and of course, did all of the people who'd like to, who will prepare them, implement them, and also trying to come up with the definition of the personal quality, and the publication of these guidelines are very important in terms of the preparation of these guidelines. And this is the contingency plans and how we can report everything, and there should be a procedure for reporting. And those patients who did not come to treatment or who did not receive treatment, they also need to be registered and followed up. And sometimes they drop out of the system. And of course, this is also, and the family education and the education of the patient is another important issue. Before implementing the new chemotherapy protocol, first diagnosis should be pathologically verified, and the staging of the cancer and the current stage of the cancer, the medical history of the patient, physical examination registrations, hypersensitivity reaction history. This should also be taken into consideration before before starting the procedure. Before each and every treatment, we need to have the consent of the patient, and with the new chemotherapy protocols, there needs to be national and international references, and which protocol is going to be used with which researches, and these also need to be defined. And there are some protocols for the research medicine, and this guideline just helps us. I'm sorry, I'm just a little bit faster because of the time. And of course, first of all, who will just call for the chemotherapy and the preparation of the chemotherapy, its distribution and its implementation? So these all of them should also be medicine implementation. If this medicine is prepared from outside, there are also guidelines for these. And also after the chemotherapy, we need to follow up. We need to know about toxicity and the complications which might follow the chemotherapy. And because of the toxicity, sometimes the doses should change. So this is a very comprehensive guideline. What do we have apart from these? We in the United States of America, there is also the Occupational Safety and Health Administration, and you could just see some guidelines and which medicine should be present in the workspace. There is the USB General Chapter 800, and they have the lists of hazardous drugs, and there is the list of these drugs, and there are the names of the medicine as well. And of course, the oncology nurses union lists are updated all the time. What is the current situation in Turkey? Of course, we have the policy procedures, and we have the updated guidelines, and one of them is the quality standards in healthcare, and we have five different stages of the quality standards. We have institutional services. There are two items and 8 standards, and these standards in chemotherapy services. What are you should have rules and procedures just like in the international processes, and of course you need to have a safe physical environment, and the preparation of the medicine and the rules and principles to be to abide by. And also there is the outpatient chemotherapy procedures. And the other standard is the control of the chemotherapy implementation processes. And last one is training the patients and the patient's relatives in terms of the treatment processes. Of course, in 2004, we have a safe medicine implementation updated guidelines, and it was published in 2009, and I think it was updated recently. It's about the antineoplastic medicines preparation and implementation. There is also chemotherapy unit standards, and this is another guideline that could be beneficial. So, are these guidelines really guiding us? These are my last slides. And of course, what are the responsibilities within the system? And of course, when we are face to face with the patient, what we can do is to speak up. So, speak up is the word that you could use. And of course, whenever there is a wrong implementation, or when you suspect something, and you just stop the procedure and you talk to them. Why is it so? How can we do it better? Do you think that it's a mistake? You have to talk as nurses. It's not only speak up for yourself, it's to speak up for the patients, for the relatives. So whenever they notice something unusual, they have to speak up and they have to talk to the nurses, they have to talk to the doctors. And this is else says the same thing. The patients and relatives should be encouraged to speak up about the wrongful acts and suspicious acts. I think, we have great responsibility, and we do them in our clinical practice. Maybe this is one of the most important points from our presentation. And of course, how are we effective in our own institution to manage these medicines? Maybe the institutions could just have an oversight of their policies, and of course we have the logistics, prescription, implementation, management, and these are some of the issues that we need to be very careful. And there was another study in 2018 and 2019. And there is one institution from our country, from Turkey, and this has been conducted with 53 institutions, and we saw that in the institutions the safety protocols implementation is around 63. And these countries were chosen from low and middle income countries, and there's a request for the prescription, and the personnel who are pregnant, who are breastfeeding, were not included. But the most important management is the cleaning sector, and of course control of these personnel on a regular basis is a lacking point, and also the preparation of the medicine is another lacking point. These are live documents. The guidelines are live documents. Of course, with the procedures is changing, they are updated constantly, and of course there are some recommendations for the new infrastructure of these institutions, and our association could just provide these guidelines to us, and you could also see from our website about these recommendations for safe medicine implementation, and we can strengthen all these implementations. Thank you very much. We would like to thank Professor Akyar for the updated guidelines. This is quite important as nurses. First, we will just act in accordance with the principle of not giving harm to the patients, and the Oncology Association has been working and exerting effort to have safe medicine implementations. Are there any questions or contributions from our friends? I think you can hear me. Thank you very much. This was a very important topic. Each and every presentation was important, but this medicine It's not only about the wrongful implementation of medicines, but also waste of medicine. Well, we were talking about the physicians, the nurses, and the pharmacies. And of course, they have their own responsibilities. What about the pharmacies? And of course, they are also responsible once the medicine is in the market, in the stores, in the pharmacies. They have their responsibilities. Well, I'm talking about the year 2000s. Pharmacists, and of course they have their own responsibilities, and they do of course at some point we need to have pharmacists. Well, I could just answer from the point of hospitals. Yes, the pharmacists could be in the background for the storage, for the supply of the medicine, especially the preparation of the chemotherapy medicine. Our technicians are mostly taking up the role, and the pharmacists help. But the clinical pharmacists are working whenever there are adverse effects of the chemotherapy medicine, and we could just get the information from them, and they have their own recommendation and proposals. But we don't have clinical pharmacists everywhere. Pharmacists are mainly in the storage and also in the supply. I know that they don't have roles right now, but we have discussed this with the pharmacists. And I think that there is also the financial aspect of it, and I think the pharmacists should be in the processes. It has just started, and we know from our PhD graduates, pharmacists who are PhD graduates. Oh, I hope that we will have clinical pharmacists everywhere. Thank you very much. Thank you very much, Imatullah. It was a good summary. I didn't know about the control list. This is the first time that I'm aware that there's such a list. In 2003, as the Oncology Nursing Association, I was in the group for the preparation of the guideline, and I was in the ministry. And in 2009, I was in the same group while updating and it's now again updated. And as we have discussed this with the ministry, the guidelines have no authority for sanctioning, and of course we wanted them to be as directives, not as guidelines, because when it is a directive, then you have the power and authority to sanction those who might violate all these procedures. And they've told us that they will take this into consideration. If it is a directive, I think we will have more sanctions. Thank you very much. Is there anyone who have other comments and questions? Thank you very much for your presentation, and I'd like to just leave the floor for the second presentation.
Herkese merhaba.
Hello everyone. First of all, I want to make a change in the introduction. I'm not a physician, I'm a nurse coming from Hacettepe University. I want to thank Imatullah for making this presentation about practices of drugs. We are personally implementing them, and the information was really valuable. Now we will have another presentation by Canan Sürücü, and she is a specialist nurse and she will tell us about catheter use and catheter care. First of all, I want to thank you. I would like to thank you very much for being here since the beginning of since the morning. We have listened to your presentations, and I will go back with all the lessons learned. And I compiled this evidence-based application in catheter care. I wanted to compile them, and I prepare a 20-minute pill information for you, and I will talk about the different types of catheters, and I will talk about care applications. Intravenous applications are main parts of the modern therapies every year in our country. More than 20 million applications are used, and we are using invasive methods. Intravenous approach is one of the most used invasive methods, and when doing chemotherapy or parenteral nutrition or vesicle, in order to decrease the side effects of the vesicle drugs, to collect stem cell or transplant them, we are using these IV catheters, and we have peripheral catheters and central catheters, and we have permanent, temporary ones, and we are using them very frequently. And about these applications, I can say that there are some international standards, and we are trying to make sure that this IV treatment is provided in accordance with some standard, and this changes, these kind of approaches changes the quality of the service. So why should we use these kind of applications? Central venous catheters or peripheral venous catheter use can cause various complications, and it is a really important thing in the patient care. And firstly, we can talk about the infections, of course, and we can have some other infections because of the blood circulation, and they are composing of 30 or 40% of these kind of cases, and most of them are created because of catheters, and its rate is about 45%. And you can think about the cost, of course, at this point. The infections, these kind of infections are causing longer hospital stays for those patients, and it is increasing the cost for these patients. Mortality is increasing, and also the mortality rate is about 20% or 50, between 22 to 12 to 25%. During intravenous application, a drug can be administered to a different part, and this is called extravasation. And you know, we are dealing with chemotherapy, and extravasation is a very great problem and oncological emergency for all of us. And evidence-based applications are really important. We want to decrease the mortality, morbidity, and the loss of labor. We want to prevent the increased cost, and we want to decrease the hospital stay time. We are using these kind of applications for this main purpose. And we have a multidisciplinary and integrated, holistic approach that is needed to prevent the infections, and the whole world has acknowledged that. And now we have evidence-based application, clinical experience, scientific trial results, and patient preference are important in making the decision about that. In our country, we are using this guideline, and I am also using this all the time. Venous catheters should be inserted in a safe way. They should be managed and they should be removed in a safe way too. And we try to decrease the amount of complications. This guideline is very useful in this regard. And in fact, when we look at the resource of the infections resulted because of the catheter, we can see there are 3 reasons. This might be because of the skin flora. In the opening of the entry place of the catheter, we can have some problems, or it is not, their hands are not hygienic. They might skip a step of the hygiene, or there might be a problem about the disinfection. Or rarely we have some problems about the serums or the drugs that are infected. Sometimes when we open a serum, we are very careful. We check whether there is any leakage in it, and we have a pharmacovigilance, because this might cause infections. We don't experience this very frequently, but it is possible. So by looking at them, by checking on them, we can prevent some cases. So we have some trainings. We are providing trainings to prevent these kind of cases. And here you can see the first evidence about this, as in all studies, all presentations. I will talk about education and training. The healthcare professionals should know how to use the catheter in a safe way, and they should receive a training about this, and its evidence level is 1A. So all the guidelines say that the team who are working with catheter should be trained on the use of it. And peripheric venous catheters, and of course for all the other catheters, we need to use a solution, 5% chlorhexidine and 70% alcohol solution. You know, this is used in all guidelines, but if you are not able to use that, povidone solution can also be used. But the first evidence-based approach is this chlorhexidine. If not, we can do other things. And secondly, when the selection of the catheter place is important. For the safest application, we want to have a peripheric venous catheter placement areas. Of course, we would like to have these kind of patients with these kind of veins on the picture photo. And we are working in oncology, and you're all smiling, and generally, I see these kind of arms because there are fragile veins and the thrombosis in the proximal veins, child patients, lymph dissections, radiotherapy patients. These are all in our clinics, and oncology nurses are trying to put catheter to these patients. And for this reason, they have a high risk, and this is a high-risk invasive intervention, and because we can have these kind of results, and we are generally using central catheters. We don't want to use them because it is more invasive, but sometimes we need to continue with the central catheter, and we are using drugs which might affect their veins. We are using hemodialysis, plasmapheresis, and we are collecting stem cell, and we need the central catheter. And for blood and blood products, the massive transfusion, we may need to use these central venous catheter. And during the opening of the central venous catheter, everything is really important. Interventional radiology or all those personnel who is doing this should be very careful. They should focus on all the steps of the hygiene. So infection control starts at the second sterile gloves should be used. Sometimes we see that in the clinics they are using non-sterile gloves, and we should prevent this. We should not do this. And before every contact with catheter, hand hygiene should be taken care of. So how can we prevent this in the field? Might be a question. Maybe you are in your night shifts and you're working with insufficient personnel, and in some guidelines it is stated that in the field there should be a car for dressing change. And on all stories, you need to put the sterile gloves and chlorhexidine and alcohol solution, so they will see that it is already here, and they know that they will need to use it. It is much more practical. So this is my recommendation. In the field, it is quite successful. And central when we are inserting these catheters, the solution is 5% chlorhexidine plus 70% alcohol, and we can also use COVID onion as an alternative. And some guidelines recommend body cleaning too. So if this is a kid patient or if it is an intensive care patient, then you can use this. CDE has a bundle about this. I want to share this with you, but I will tell you about the other guidelines. I will show all the recommendations together. There are some products which are easy to use. For example, we're putting the chlorhexidine solution on sponge, and we clean the catheter into the area, and then we close it. But there are some innovative products, and we can find them in the field. These are called Lollipop, and we have chlorhexidine gluconate on the tip of this, and two firms are producing this. These are applicators. If you have them in the field, it is quite easy to use, and you can do this. You can just directly clean the area with this. And in terms of using, it is quite easy. I wanted to show you an example. During this part, the older guidelines are recommending one thing: 2% chlorhexidine soaked catheter closures, lids can be used. So on every shift, the nurse can check the catheter and they look at the paints or the colors, because we say that we should change these covers in 5 or 7 days. But when we use sponge, we cannot see what is happening, what is going on underneath it. We have to change it every 3 days because of this. But for these ones, we don't need to wait. We can wait for 5 or 7 days, because we can see what is going on underneath it, and if we can control the infection, whether there is an infection, and we can do what is necessary. So if there is a problem about the integrity of the covers, if there is some quite visible dirtiness, or if there is blood or drainage liquid under the cover, we change it immediately. We do not wait for 7 days. And lumen tips, this is another part of infection to start or develop. We were using them in the past. We were using 3-way. But we are not using them anymore. So these are mentioned in guidelines. They're causing infection, and their hook entry is, I wanted to share in the picture. We are using vein connectors without needles, and we should use isopropyl alcohol 70%. There are single-use lids, and many firms are producing them, and guidelines are recommending the use of them. And the hook entries, we need to provide a manual disinfection, and once we remove the lid with alcohol, we can put the serum set or needle tip and then continue with our intervention. If we do it so, we will eliminate all the possibilities of infection. And needle-free connectors change time is 96 hours. And other products, catheter Lyme infections and pocket infections, it is recommended 10%, 10 cc, 9% sodium chloride is in here. Double piston positive pressure technique. It is called Verdure technique. It is called administer and stop, and this is, we give 1 millimeter, so for 1 seed we will give 4 seconds. So we are then stopping and then giving again. So we are washing the inner parts of the catheter. Why are we doing this? In order to eliminate the prevent pocket infections, and they say that this is the best technique for colonizations. There is a product in the market. I found this from one firm. It has double pistons, and there is an injector, and you can do the washing with that, and it says that you can then prevent infections within the catheter and or colonizations too. There is some short information about the sets and change of these sets. The sets should be changed in every 96 hours. The blood product sets should be changed after the treatment. And the first dose used for TPN should be changed every 24 hours. Propanol sets should be changed every 6 to 12 hours, and every day and on every shift we need to check the catheter area. We need to check whether there is any problem. We need to take the note of this on the nurse observation papers, and you need to inform them. So the recording is really important. As soon as the need is over, the catheter should be removed. This is a recommendation, because that should be removed under sterile conditions, and we should have a catheter card for all, which includes all the materials that can be needed during the catheter insertion or removal, and we can check the cultures. To sum up, healthcare professionals should be informed about the catheter use, its management, its infection control, and other aspects. They should be trained, and we can use in-service trainings for those patients. And we want to increase the infection of blood circulation, decrease infection, and hand hygiene is really important in this regard. Chlorhexidine use must be more widespread in the field, and antiseptic solution should be on the skin, and we should wait for it to dry by the air, and once it is dry we should close it, and we need to prepare checklists for this. These are my resources, and this is all from my side. Thank you very much. We would like to thank Ms. Furuji, and she finished just in time. I want to ask if there is anyone who would like to ask a question to her. Thank you. I want to underline one thing. You said povidone iodine use. It is problematic actually. Chlorhexidine should be used mostly. Our colleagues should choose it because there might be non-permeable parts, and So in each catheter use, we need to control it, whether it is permeable or not.
Teşekkürler. Peki başka katkı veya sorusu olan?
Any other questions, comments?
Evet, ben teşekkür ediyorum.
Okay, thank you very much. Catheter use is really important. I said it before, as we are clinicians, it is one of the most important issues. And almost all of the hospital, half of the hospital infections are caused by catheter-related cases, and we all know that. And the figures you give are quite impressive, and there are many things to do. We need to define the material, and we need to know how to insert them in a healthy way. And we are touching these catheters very frequently. It is not used in the in intensive care units. We are using them in our clinics. So the training of the applicants is really important, and it was a great presentation because you underlined the importance of that. Thank you. And now we will continue with the third speaker. We will talk about the intravenous, central venous catheter tissue study. This will be a single center study. Turgay Eker will make the presentation. The floor is yours.
Değerli misafirlerimiz, hoş geldiniz.
Distinguished guests, I'd like to welcome you all. I will talk about a study that I have finished, and it's the central venous catheter obstruction due to tissue plasminogen, and my presentation will be composed of entrance, materials and methods, results, argument and conclusion. CVC is one of the dispensable tools in modern medical practices, are used in many units, including central venous catheters have been used with kids, and it was laid for the first time in 1929 by Dr. Werner, and there are different lumens with different dimensions, different sizes, and I will be talking about double lumen catheters. This is the cuff, and its use is to reduce the risk of infection and prevents catheter from coming out. And this is the internal. This is. Central venous catheter lumen in catheters, according to usage methods, the recombinant tissue plasminogen is used to reduce ballooning, clogging, or tearing that may occur and prevent. And it is aimed to reduce the use of activator. Central venous factors affecting the luminal utilization of the catheter. Fluid replacement in patients requiring intensive treatment, total parenteral and peripheral parenteral nutrition products, transfusion of blood and blood products, and flow rate of liquids, and catheters not being heparinized or flushed. And duration of the use of catheters, drug applications, administering incompatible drugs one after another to prevent criticization of drugs, and infusion sets should not be changed within 72 hours. Of course, the preference is Hickman used in catheters, and the flow rate is proportional to the inner diameter, not to outer diameter. The larger the internal diameter, the higher the flow rate, and the lower of the risk of thrombosis. And after these observations, there were two lumens, and why they are obstructed. And I just wanted to have another research, and together with the interventional radiologists, as we were just investigating the central catheter, we just wanted to look at in the Hickman catheters. They are enlarged, and of course this was related to the outer diameter, not inner diameter, and of course the thrombosis risk should be reduced. When we look at our targets, of course we wanted to reduce the obstruction due to the use, and of course we wanted to have lumen preferences standardized, and also trying to reduce the cost. Our study was conducted in between the 1st of January and 30th of July 2020, and double lumen central venous, and it was performed on pediatric hematology oncology patients with catheters, port catheter, and peripherally placed intravenous catheter children and the research was planned prospectively, and the research was planned prospectively and as a data collection tool in this study. In this slide, of course, we wanted to train our nurses about the right kind of lumen, and that we could decrease infection, and we have given them the necessary training, and we have had some practices as well, and we just wanted to follow them and in this the red lumens and white lumens, what are we going to use with them? And of course we will have protective antibiotics, and we had chemotherapy, medicine, blood products transfusion, TPN, PPN, and defibrate infusion. And if they are using only antibiotics, this could be and of course we just wanted to just decrease and mitigate the trauma in the kids. And the recombinant tissue plasminogen activator RTPA, and they were separated in minus 80 degrees, and of course we had the different, and this is where we keep them in the laboratory. It was minus 80 degrees. Here we have the recombinant tissue plasminogen for local use for opening clogged catheters activator application protocol, and you can see that the weight is 10 kilogram or below, or 10 kilogram above, and we use 1 milligram of TPA about 10 kilograms, and if it is below 10 kilograms, we use 0.5 milligram of TPA. And of course, when they received thrombosis treatment, of course, it also increases hemorrhage. And while we are just administering, we need to have time intervals as well. Number of patients who received we have given this treatment to 139 and then 147. Patient distribution. You can see the patient distribution by gender, and you can see that the number of patients have increased. And when we look at the age distribution by age, and you could see that the children between the ages of 4 and 10 have increased drastically. This is the tissue plasminogen activator use. And we had 155 TPA dosage, and after the training we had 286 patients, but the TPA have dropped from 155 to 46, and the number of flacons is around 6. And when we look at the using of TPA usage in 2020, 22, and 2023, what have we seen as the complications after the obstructions? And we have followed up to 6,055 catheter day. I have followed up in 2022, and due to ballooning and obstruction, we have renewed the catheters. Despite the increasing of the patients, we have just renewed the catheter only in one patient, and in the other 7 patients there was ballooning and thrombosis in the other 7 patients. And when we look from the perspective of cost analysis, and as you can see here, we had $2,116 the cost, and I have used 6 flacons, and I have dropped this dropped to $604 US, and we have saved around 45,000 Turkish liras. When we look at today's literature, central venous catheters, although it provides great benefits for patients, it also prevents pneumothorax, hemothorax, thromboembolism formation, fistulization, obstruction, rupture. It increases the risk of mortality and morbidity in patients. In this study, we used central venous veins catheters used in pediatric hematology oncology clinics. We found that the complications mentioned were reduced in this study. If the obstruction cannot be removed, then the catheter is removed and another catheter is put there. And when we look at it's possible that, especially with the children and families, is due to the central venous catheter use, the use of catheter, the duration of the use of catheter is prolonged, and there are some complications, but the anxiety and fear is reduced. Of course, the catheter revision and catheter renewal of the catheter procedures have decreased, and of course the cost is also reduced. And I'd like to thank two clinical nurses here who have supported me in this study. Thank you very much. We would like to thank Mr. Eker. It's very important to avoid recurrent procedures, and it is also important to reduce the cost. And of course, our observations and outputs are quite important, and these are also reflected in the implementation. And are there anyone who would like to come up with comments? Ms. Gülcan, you have the floor, please. I'd like to thank Mr. Turgay, as you have highlighted. Of course, this is a very valuable data with concrete indicators from the clinic, and I'd like to congratulate you and the whole team. Of course, I am away from the clinic, and you have observed the catheters and the use of the catheters. You've talked about the blue catheters, blue and the white catheters, and of course there are the manuals of these catheters. And do you have such? No, I didn't see any. No, I didn't see any. Of course, you have talked about two different timelines, and this due to different lumens and but of course, is this the only one in the clinical practice? I have observed it for 4 months and 5 months, and we saw that the same catheter created obstruction. Sometimes there were ruptures as well, and I've talked about the same lumens. One of them was obstructing, and the other one was really working. And thank you very much. Have you just published the results? And if you need, of course, I would recommend EONS. And of course, you have to, maybe you could just talk about the method, and our distinguished professors will help you because you have very concrete results. This is very important, and I do congratulate once again. Well, I have a such studies are very valuable for the companies, because during the R&D, during their R&D phases of the product, with the compliance and in-compliance stages, I think this is going to be a very beneficial data when they are developing their products. Maybe you could have a prospectus, and maybe they would just prepare a prospectus, and so they are going to develop their products. Thank you very much once again for your work. The last speaker of the last session of the day, Miss Gamze Çıtırkıya. She is from LÖSANTE, and she will be talking about lidocaine spray and its relation to the pain. Thank you.
Konuklar güzel olunca güzel şeyler.
The topics are great, and I didn't even understand how we got to the evening. If we had 3 or 5 more sessions, I would stay and listen all the presentations. And hopefully all the next, all our colleagues will use this. I want to give and make breaking news about some changes in the clinical applications. You know, pain is really important. We talked about pain in different presentations. This is a universal reality. Everyone experiences pain in their lives. In order to eliminate this universal problem, we started to work in our pediatric clinics. Each child, before they come to the clinic, they might have have some pain. And normally in our treatment there might be some problems that we don't want this pain problem in our patients, both in children and adults. And as the pediatric nurses spend more time with the patients, we are trying to eliminate the pain. But our main objective is not just eliminating the pain. We are trying to focus on the maximum benefits, and we need to show that there are some evidence-based approaches, and we need to make use of them. In pain management, we have a clinical study, and we have an anxiety. Children have anxiety for port needle and cannulation insertion, and lidocaine 10% spray can be used, and we wanted to measure its effectiveness. Actually, we already used it, but we want to make an application based on an evidence. So this is why we decided to check its impact, and we had 480 cases. Their age was between 0 to 18, and 272 was in our working group, and 313 was in our control group, and we have consent from all the families in written and oral forms. And we ask questions about their features, characteristics like age, genders, intervention area, and pain scale, pain points, pain scores. And we also asked about the observation of the child's pain, mother and the nurse about the scale of the pain. This is our pain form. And in the hematology oncology services, the pediatric nurses, of course, underwent a training, and we gave this training to the working group, the test group for the lidocaine, and they were trained about the port catheter insertion. And we sprayed it from 5 centimeters, and we waited for 5 minutes. So the training was that, and we used a visual analog scale and numeric scale for pain. This is the product we use, lidocaine spray, and we selected the bottles. We have randomized approach, and in the other group we used placebo, which was chlorhexidine normally. And you can see the analysis of the data, and we use statistical programs, and we looked at the normal distribution of all the variables, and we make comparisons, and p-value was 0.05. And now let's look at 480 cases, and the number of males was higher, and age average was 7.2. and peripheric port catheter patients is equal to each other, and the scale of pain is mostly visual. And when we ask about their scores of pain, it is about 2.87. This is the pain average of all these 480 cases. And when we look at the mother and nurse points, it is about 2.05 and 2.03. So the patient's pain point is higher. Of course, it is what the patient is saying, and the nurse and mother's observation is quite close and is statistically meaningful. And when we compare the variables in the control group and the study group, we didn't see any statistically meaningful change. The lidocaine spray did not make quite difference, especially in the intervention area. But when we check the pain scale, especially in the study group, pain scale is lower. In the control group, it is higher. And in addition to this, the mothers and the nurses' observation was almost the same, and they were supporting each other. And it is statistically meaningful, and this shows that lidocaine spray has an impact, has a positive effect, and we can use it in the clinic. And it is supporting us in effective pain management. So as a result, lidocaine 10% spray was effective, and we decided to continue using it, and we continue using it, especially in peripheral catheter insertion or port catheter insertion. We are using it, and I think it will be a good thing for the patient too. And these can be used in all interventions, and hopefully we will have a support. We will have some contribution to the sector. Of course, we would like to have more studies, and then these kind of findings should be shared in service trainings, and they should be a part. They should become a part of our daily practices, and the results of these up-to-date studies should be shared and disseminated. So thank you very much. This was good news, latest news from the clinic. Thank you. Thank you. I will turn to the participants. Any comments? Thank you. This was great. We heard 4 trials, 4 studies, and they provided great contribution to the field. I totally agree with what Gülcan is saying. You said that EONs can be used, but it is oral presentation time is already over. But I said that these studies should be shared in the international congress. It should be turned into publications in order for them to be used by other colleagues. So you are implementing this in clinic, and I think you are using it frequently. It is quite valuable, and we have seen its impact, positive impact, and when it is quite valuable to see those results in this way. So we said that we have the International Oncology Nursing Congress, and its oral presentation time period is not over. Please send these trials, send these studies to those kind of events. And Turgay, is Turgay here? This was a great study, Turgay, and the number is low, but maybe in the cost, we can also think about the time of the nurse, the cotton injectors, patients, hospital stay. Maybe you could also include these kind of things in the definition of cost. And for the conclusion, I think there were 7 patients. What were you thinking about these 7 patients for the zero clogging? You need to think, or stenosis. You need to think about this, and I believe that you will find this. Thank you. Thank you very much. By the way, when you're telling us about your studies, I was taking photos to my old team, and I'm sharing these photos of your slides too with my team. But I want to ask you some questions about this, especially, you know, port entrance is sterile. You waited for 5 minutes. Did you use alcohol again 5 minutes later? Do you think it's no? I'm talking about the hygiene. We are generally using chlorhexidine. Yes, after 5 minutes, we are using chlorhexidine. Right before the intervention, we use alcohol with chlorhexidine. Thank you. You can also share some methods, details. So of course it was a question mark on our minds, so thank you very much for the question and answered. Any other questions or comments? I see a hand behind in the back rows. Hello, Dr. Ibrahim Eker. When I listen to these studies, you know, we have the chief of these studies. Emin Bey was really valuable for us, and you're really lucky. I wanted to remind you of that. I believe that you feel this because the team leader's vision is important. He is directing you, and it is really important for them to support young colleagues. And as a student of Emin Bey, I'm really proud. I'm his fellow, and I'm in Afyonkarahisar Health Sciences University in the pediatric hematology oncology department. These are really important studies. The pediatric hematology oncology patient is treated by nurses. Our lecturer said that it doesn't matter how great a treatment we prepare as physicians. This communication with the nurse is really important. It doesn't matter. We have all the information as a physician, as a doctor, but we are not able to reach the targets, and we see that in the field. So thank you very much for this, and thank you very much for those who have exerted efforts. Thank you. The team is quite lucky, as far as I understand. Thank you very much. I'm a nurse too. I would like to congratulate you, and these things are really valuable, and they're reflected in the field now. And the patient has first-hand benefits, and as I look at these kind of studies, I have taken some notes to implement this in my own field. So this is still at this time the venue is still full, and the organizing committee has prepared a great program for us. I think we need to congratulate them. I would like to thank you very much for your invitation and for your organization. I think this is the end. We will give the gifts, I think, present the gifts. I will invite the speakers to give them their certificates.
sempozyumumuzun sonuna geldik. İlk gün
We have come to the end of the first day of the symposium. Fatosh Gürbüz, I'd like to invite Fatosh Gürbüz to the floor for the closing remarks. We have come to the end of a very productive and beautiful day, and I have just listened to all the presentations. I was really happy to listen to all these presentations, and all my wish is to have this team to bring forth more detailed studies, and that we would have our university established. Today has not yet today has finished, but we have just started. Please, tomorrow is going to be a very productive day for tomorrow and for Sunday. I'm very proud of my team, and the other team members are quite important because there is teamwork behind the success. This is a non-profitable organization which is open to development, which is open to new advancements, and you have seen our facility. We could just share everything. Please continue to follow us, and so that we will be sharing your own works. And as you have seen here, what is done here is not really that different from the works that have been done in the European countries, and I think we are having a hard time to express ourselves. We are no different from the United States, from Canada, from Australia. We are really happy to meet you. I would like to thank you once again on behalf of my institution, and I'd like to thank again once again to my institution for organizing this event free of charge for the participants.